So hello to everyone and welcome to the second webinar of the Amity Alliance series on migrant and refugee health, organized in cooperation with the Association of Academic Health Centers International. My name is Luciano Saso and I'm a Vice Rector of Sapienza University of Rome in Italy, member of the Executive Committee of the Amity Alliance and member of the Steering Committee of the Association of Academic Health Centers International. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at both the annual event in Berlin and at regional meetings. In addition, we organized 3 expert meetings at Sapienza University of Rome on the same topic. The one planned in Rome in 2020 was postponed due to the COVID pandemic, and we decided to launch this series of webinars. We organized the first webinar on January 28th on the impact of COVID-19 on migrant and refugee health in cooperation with the Lancet Migration Commission. On March 30th, we will have a webinar on ensuring that COVID-19 vaccines reaches undocumented migrants in cooperation with PICUM, the Platform for International Cooperation on Undocumented Migrants. On 19th of April, we will have a webinar on digital solutions for migrant and refugee health in cooperation with the London School of Hygiene and Tropical Medicine. On May 27, we will have a webinar on strengthening healthcare systems in Europe while improving migrant health in cooperation with the NGO Emergency. More information and the link for free registration is available on the World Health Summit page dedicated to migrant and refugee health. Today's webinar on the migrant health issues in massive migration areas in the COVID period has been organized in cooperation with the Association of Academic Health Centers International. And I would like to thank very much Stephen Cantor, President, CEO, and Mohammad Sayag, Chair of the Steering Committee, for agreeing on this initiative. I would like to thank very much Ozge Karadak-Kaman for chairing the panel and all the distinguished speakers for accepting our invitation. Thank you also to Stephen Matlin from the Institute of Global Health Innovation of Imperial College London, who will be the rapporteur of this meeting. For the organization of the webinar, I would like to thank very much Nora Anton and her collaborators and the World Health Summit team, and Christine Smith and Abiba Osmani at the AAHCI. I hope that Dr. Sayad managed to join us now. I see if he is not online yet. I wanted to give him the floor now, but in that case, I will do that later during the webinar. And we will continue now with giving the floor to Ozge Karadak-Kaman, who will chair the panel that we are going to have today. Ozge works as a senior researcher at the Center for Sustainable Development of the Earth Institute at Columbia University. She is also Associate Professor of Public Health in Turkey. Dr. Karadak-Kaman has more than 15 years of experience in conducting research, developing public health policies and programs for different vulnerable, disadvantaged populations. She has worked as a consultant for numerous UN organizations and European Commission. Her current work focuses on research, advocacy, and training activities regarding the effects of the COVID-19 pandemic on the most vulnerable populations, including migrants and refugees, and how to use innovative outreach approaches and digital technologies to increase access to health information and healthcare among refugees and disadvantaged local youth in Turkey, Lebanon, and Jordan. I would like to thank very much all the participants for being online today and invite all of you to ask questions in the chat in view of the discussion which will be open after the presentations. I wish a very pleasant and fruitful meeting to everyone, and thanking again you, Ozge. I give you the floor, or the screen, we should say.
Thank you so much, Luciano. So as you all know, currently international migrants represent about 3.6% of the world's population. There's still lack of data about the current situation of migrants and refugees and how governments respond to their needs in many countries. However, existing trends show that they are among the most vulnerable populations that are disproportionately affected by the pandemic. This panel brings together well-known experts from around the world to discuss main challenges that international migrants face and urgent solutions to promote their physical, mental, and social health during the pandemic. Today, our first speaker is Professor Shadi Saleh. Dr. Saleh is the founding director of the Global Health Institute at the American University of Beirut. And he is a professor of health systems and financing at the Faculty of Health Sciences at AUB. Dr. Saleh's areas of expertise are in developing and evaluating innovative interventions for health systems in fragile contexts. Dr. Saleh is an elected board member of the Consortium of Universities in Global Health and represents GIH on the M8 Alliance. He co-led the Health Systems and Rebuilding thematic group in the Lancet Commission on Syria. So Dr. Saleh, the floor is yours.
Thank you, Luciano. Thank you, Ozge, for the introduction. I think I should share my screen to start the presentation.
Yes, please.
Can you see it now?
Yes, we can see the screen.
Okay, perfect. So the title of, I only have 10 minutes. The title of my presentation is Refugee Health in the Arab Region, to discuss a little bit with you how such a regional challenge can have a global impact. I move forward to also argue that every regional or every refugee health challenge is actually has a global impact irrespective of what the region is. So basically, health in general within the global agenda has been an important component of the MDGs, Millennium Development Goals, as well as the 2030 SDGs, particularly goals 3.8 and 10.7 that discuss more ensuring healthy lives for all and the leaving of no one behind when it comes to health. In 2017, the 70th World Health Assembly endorsed a resolution that was specific to the promotion of health of refugees and migrants, and that resulted in WHO's Global Action Plan for 2019-2023, which builds on that resolution. So in general, as part of the global agenda, both from an SDG perspective and also from a WHO charter, refugee health is an important component. Now, going deeper a little bit and asking ourselves, why would a refugee crisis, be it in the Arab region or be it in Latin America or in Africa, why does it have a global impact? So, because one, if we look globally, refugees and displaced populations are often among the most vulnerable of populations, not only because they are refugees, which by itself is a vulnerability, but also because the makeup of those refugees are mostly women, children, and elderly, who are even more vulnerable as a population. And the second point is in most of the times, we think about refugee populations in two dimensions. The first is political, global politics, and what have you. And second, from a humanitarian standpoint alone. But in actuality, from a global perspective, even beyond global politics and humanitarian issues, the issue of refugees have a direct effect on global security, as we have seen in recent years in different parts of the world, and also in the global economy and economies of both the immediate host communities and the target host communities. So this is from a refugee perspective. Now, zooming in on the refugee health, is we have seen that throughout history, health becomes the basic need that is first to be compromised, because individuals think first about fleeing, and whether they are economic refugees or conflict refugees, fleeing where they're at, then they think about, as part of their fleeing, the security issues related to basic livelihood. And in most instances, and studies have shown that, is that health or health challenges remain or fall down in terms of priorities, which is big. Now, again, what about the refugee crisis in this region of the world? I think it's important to say, and we have many experts with us on the panel, that this region is the epicenter of the global refugee crisis. It's just important, or it's enough to note that approximately, this should read one third of the total number of refugees worldwide are from this region. And if we look at this slide, we see that the migration journey of refugees from the Arab region is one that is rather complicated. It does not end in one country. The migration journey happens across different countries, and mostly they aim in the global north. In this case, from our region, mostly in Europe, with a lower percentage also going to North America. So when you look at those migration journeys from this part of the world, we have to understand that there's a very intricate dynamic that happens between the health needs of the refugee population and the health system, both in the interim host countries and in the final host destination. And this, what I mean, will become clear in a little bit. So the first is, in most cases, as part of the refugee journey, that happens from countries in the region to other countries in the region before they can sort of go further north to their, ultimate final destination. However, if you think about those intermediate host countries and their health systems, they themselves have main challenges, including physical, human, and institutional infrastructure, poor ones, with usually lack of surge capacity. The intermediate host countries also themselves, in many cases, suffer from insecurity and instability, which adds or multiplies the burden both on these host countries as well as on refugees. They have protracted emergencies, and themselves they have forcible displacement for some of their populations. An example is in the region is Iraq. Iraq had to absorb refugees from Syria, but themselves also had a problem with IDP, internally displaced populations. There are in many parts of the region ongoing conflicts, no foreseeable resolution in place, meaning that the refugee who leave, or those that leave, there is a great challenge in them going back. And I think that we have seen that in the past, perhaps 30 years, in countries such as Iraq, where many of their refugees never actually came back after the place was in a little bit of peace, the country. And there's also the issue of uncertainty, economic burden, and also politics, which play a big part in the movement of refugees, even later on, and also between the country of origin and the host country. So what I will be presenting to you after this introduction is three case studies that focus specifically on the Syrian crisis, and 3 sort of intermediate host countries that include Lebanon, Jordan, and Turkey. And the reason why I am doing that is just to highlight to you how the different health systems in those 3 countries dealt with the refugee crisis. Now, we start off with Lebanon. Lebanon was greatly affected by the Syrian crisis, currently has more than 1 million registered refugees from Syria. We have to remember that Lebanon also hosts 500,000 approximately Palestinian refugees. So all in all, Lebanon has the highest number of refugees per capita. Lebanon made a decision early on that there will be no sort of concentration of refugees in settlement camps. Rather, they would be distributed or free to reside wherever they want within the country. The health component of Syrian refugees have been a collaborative effort between the Lebanese Ministry of Public Health, UNHCR, which is the higher council for refugees, the UN Agency for Refugees, as well as NGOs and humanitarian agencies. Now, interestingly enough, through many factors, the Lebanese healthcare system was able to sort of withstand the influx of such a big number. I always give the example of countries such as Egypt, which has 100 million individuals, and what happens if in few months they had an additional influx of 30 million individuals, or the US, which has 350 million population, and suddenly 100 million Mexicans just crossed the border and needed all of the health and so on and so forth. I think that the factors that allowed the Lebanese healthcare system to withstand this influx is, one, it was mainly comprised of a public and a private healthcare delivery system that both had a little bit of surge capacity. So that allowed for definitely for that influx of refugees because of the surge capacity, and also because in most instances UN agencies and NGOs were very active in doing that. And remember, there was a decision early on that the refugees will be spread all across the country, meaning that there wasn't specific pressure on the healthcare system within any of the regions. The problem that emerged later on, I would say starting 2015, 16, 17, is that because the refugee population was getting subsidized healthcare in healthcare facilities, both public and private, through UNHCR and other NGOs, that had an impact on social stabilities where the Lebanese didn't have as much coverage as their Syrian counterparts. And that was also a critical time where the whole design of support for health had to be re-engineered so that it was Syrian and support for Syrians and poor Lebanese. And that is a very important change. So 2 main changes: the system was resilient in terms of infrastructure and surge capacity, and the need to re-engineer the support so that it also includes Lebanese and not only Syrians. The second case study is in Jordan. Jordan had a mixed approach to refugee health or refugee displacement. A considerable proportion or a good proportion of Syrian refugees were based in settlement camps like the Za'atari camps, and others were spread throughout Jordan and Amman and other governorates within Jordan. And basically, because of that mixed approach, the Jordanian healthcare system, because it has a strong public delivery system, it was also able to absorb that with obvious impact on the economy. However, an interesting thing that happened in Jordan is also the private sector, as a result of that huge influx, also increased its capacity in the last 10 years. The third case study is in Turkey, and I know we have on the panel colleagues who are more familiar with the Turkish, how the Turkish health system dealt with the refugee health. 3.6 million Syrian refugees moved to Turkey. It's the highest number of refugees in the world in a country. Now, Turkey had, as far as I'm concerned, a very interesting and good way of dealing with refugees. Remember, Turkey is significantly larger than Lebanon and Jordan, both in terms of geography and in terms of the number of population. However, they did something that was interesting, which is trying to capitalize on Syrian health workers to treat Syrian refugees. Again, 3.6 million refugees, the number is huge. What they did is they established migrant health centers, and which was, I think, a factor in that decision is, remember that there's an issue of culture and linguistic barriers, but with that good policy planning, definitely that was an important factor in that. So this is my last slide. Conclusions is that almost all regional refugee crises have a global impact, and we saw it from the migration journey. That migration journey passes along fragile settings, and it interacts, is affected, and also affects the host country's health system. The good thing is that the burden on the final destination can be managed if proper planning happens and there is a support, global effort on how to deal with this. And then beyond politics, refugee health should be a collective global effort. I invite all of you to engage with us at the Global Health Institute. We have a refugee health program that is specifically dedicated to refugee health. So I would like to thank all of you, and apologies for taking a little bit more time. Thank you, Ozge. Back to you.
Thank you, Professor Saleh, for this very informative presentation. And our second speaker is Professor Amir Takian. Dr. Takian is the chair and professor at the Department of Global Health. I'm so sorry. Global Health and Public Policy and Vice Dean for International Affairs at the School of Public Health, Tehran University of Medical Sciences in Iran. He is also advisor for medical education reform and member of the National Examination Board for Health Policy, Economics and Management at the Ministry of Health and Medical Education in Iran. Dr. Takian is Chief Research Officer at the Health Equity Research Center and a focal point at M8 Alliance, serving as a member of the World Health Summit Executive Committee since 2017. So, Dr. Takian, the floor is yours.
Thank you very much, Ozge. Can you hear me and see me and my slides well, all?
Yes, we can see you,
okay.
And the slides are here. Thank you.
Thank you very much, Ozge, for the nice introduction. And thank you, Professor Sazo and Nora and all colleagues in M8 Alliance for giving me the opportunity to discuss about refugees' health as a building block for peace and sustainable development in my country, Iran. The thing is, it's very difficult to talk about the story which has been unfolding in the course of last 4 decades in my country, which is very important. And we know it is not just the obligation, it is not just the human issue. It is how we need to manage the arrival, the human aspects of the issues of refugees, specifically when we look at my region. All of us, Shadi mentioned about Lebanon and the case study of Jordan. When you look at Iran, for instance, and when you look at the global picture, as you mentioned at the beginning, Ozge, almost 1% of the world population have fled their homes as a result of conflict, persecution, and this kind of stuff. And if you look at the distribution of these people, you can realize that our region has the highest number, and a small country like Lebanon has the highest number per capita. And the case in Iran is not that much serious, but it has been hosting millions of refugees, asylum seekers, and migrants specifically from Afghanistan and Iraq. Why I have the right to talk about this? Because I have been working as the leader of a team at Tehran University of Medical Sciences who has been looking at the issues of refugees and sustainable health development, and specifically among Afghan refugees. So I've had a number of PhD theses and national projects, and currently we are involved in an international project which looks at health and peace from the lenses of sustainable development. Unfortunately, I don't have time to go much further to this conceptual framework. What I would like to say is sustainability with this 5 P's, specifically peace as the cornerstone of sustainability. And then when you look at the pillars of positive peace, then you come to the conclusion that sustainability is not possible without peace. And peace, specifically in the countries like my home country and many countries in the Middle East, is not possible without looking at the issues of refugees' health, and for refugees' health, particularly universal health coverage, and leaving no one behind, which is the general motto of the World Health Organization, matters a lot, because when in the countries when we have a mass migration, we have a mass number of refugees, it is impossible to reach universal health coverage and sustainable health development without looking at the issues of refugees. And when you look at some reports like Ecological Threat Register 2020 and the number of 20 countries with the most displaced people from disasters, for instance, you realize that a number of countries are there, and unfortunately my home country is among them. So we are facing a kind of double burden of accepting refugees and being prone to lose our population because as displaced people. So that's why if you look at these red countries, you can see that Iraq, Iran, Afghanistan, Pakistan, and many sub-Saharan African countries are among those countries suffering from these issues, and which again may compromise peace. And that's why we need to look at this issue very, very vividly. My home country, we have almost 84 million population. The life expectancy is not that much bad. Compared to the region, is good. And then when you look at the mortality and rates and the outcome of the health system, it compares with many similar upper middle income countries. So in that case, we do have a kind of good and stabilized situation in Iran. And when we have, because we have received a number of refugees from Afghanistan, in the course of last 4 decades, we have been trying to integrate our health policy making and our health reforms in order to account for refugees' health in terms of their right as normal citizens of Iran to medical services, education, literacy, and labor market, and everything, which I come to that with some just minor examples because I don't have time to go to all of them, just to give you a kind of flavor of what has been happening in my country. In order to understand the system, it is very crucial to understand the health system and health system structure of Iran. I don't want you to go to the gist and to the details of this flowchart, but one main message of this is in Iran, we have a kind of pretty much unique structure of the health system because we don't have, I mean, for us, the medical education since 35 years ago has been integrated into the health system. That's why our medical universities across 31 provinces, we have 67 public medical universities. And these medical universities, which are under the patronage of the Ministry of Health and Medical Education, are responsible for providing healthcare to the citizens, refugees, displaced people, migrants, and residents alike. So that's why we have a kind of a strong and very diverse system of medical provision of services, medical education, and research across the country being governed by the medical universities in 32 provinces. I think these numbers are interesting. I've just put some countries, and including Lebanon, when Shadi mentioned the example, just to compare the number of refugees. And just to let you know, in 2019, when we have this number of refugees, we have Professor Selma from Istanbul, who will be talking about the issue of Turkey as well. But in Iran, the case is a little bit different because we have almost 1 million Afghan refugees who are documented, and almost 30,000 refugees from Iraq. But almost 3 times of this number, 3 million people, are undocumented refugees. So this somehow brings us to the number of 4 million, 3.5 to 4 million population who are refugees. The majority are from Afghanistan in the last 4 decades. One thing which is shocking is the gap that we have in terms of the financial resources available for these refugees. You can see that ours is the highest compared to the whole region. The reason is, in the course of last 4 decades, Iran has been providing these services for refugees almost free of charge and out of domestic resources. So the contribution of UNHCR and international agencies compared to other countries is very low. And and the majority of these refugees are embedded in the society because they live not in the camps, they live in the society and with other Iranians. So that's one of the main differences that we have. And in terms of the support that we have, just to put it in a very summary, we have a number of upstream policies which supports refugees' health. So refugees have their same rights in many aspects compared to the Iranian citizens. And some examples are free access to primary healthcare services. These primary healthcare services are almost everything, from vaccination, health promotion services, prevention, even treatment. And then they can access to hospital and other expensive secondary and tertiary care with 10% copayment. And this 10% copayment, I come to that in next slide, in many times it can be compromised and can be neglected. So again, they can enjoy these services even though they are undocumented, they can enjoy that. There are special arrangements for mental health care services for refugees. And then, for instance, there's a number of NGOs who are supporting refugees in Iran. There are specific clinics in big cities like the megacity of Tehran, which provides mental health consultation specifically for Afghan refugees in the partnership between municipality and the Ministry of Health. Access to community-based rehabilitation services for refugees with disabilities, and this is almost in all provinces of Iran, and improving maternal health in Afghanistan and among Afghan refugees in Iran, which is a project that we have been doing with UNFPA and the governments of Italy in order to provide Afghan refugees and Afghan citizens within Afghanistan for maternal health care. I don't have time to go to the details of this, but this has been a kind of South-South collaboration that the government of Iran has been doing through the facilitation of UNFPA for Afghanistan. These are some of these photos, and these are the NGOs, some NGOs which are providing the services in collaboration with the Ministry of Interior, Ministry of Health, and the Ministry of Education in Iran. For instance, Zanjire Omid in Farsi, it's the chain of hope, which provides free consultation, even the financial contribution for the healthcare of refugees. And some photos, for instance, this photo is an Afghan midwife who works in the Tehran hospital in the very friendly and specifically designated maternity ward for Afghan refugees in the city of Tehran. And the different kind of services in maternity, primary health care, secondary care, community-based rehabilitation for Afghan refugees in Iran, which has been happening. Since 2015, I'm coming to the end of my presentation, just 2 more minutes. 2015, we have been providing universal health coverage services for Iranian population in a mega plan, which was called Health Transformation Plan. So in collaboration with UNHCR and the Bureau of Foreign Affairs in the Ministry of Interior, we have something which is called Bimeh Salamat Vijay Mohajirin, which is immigrants and refugees, a specific health insurance towards universal health coverage. And in that, we have providing financial sustainability for our refugees, and specifically Afghan refugees. And we started with documented Afghan refugees. And if I want to show you the kind of results of that in this collaboration, universal public health insurance has been provided for them. And a number of organizations are involved in that, as I said, including the private sector. I don't want to go to the details of this, but the point is very small co-payments for admission in the hospital for documented and undocumented has been provided since 2015 for Afghan refugees. And as I said, because of the NGOs and these charities, even this 10% co-payment can be overlooked if they are supported by them. But the problem is, and I want to finish with mentioning some problems that we have in terms of the challenges for providing healthcare services. And those problems are socioeconomic issues like financial problems, illegal residency. Some of them are afraid that if they refer for having this insurance, they will be deported to Afghanistan. Lack of valid identification documents, unsuitable accommodation, low literacy, high prevalence of mental illness, and communication problems. Afghani people, they speak Farsi, the same, exactly the same, but in the different dialect of Farsi. So there is not a kind of language differences, but there are some kind of limitations in benefiting because some Afghan refugees mistrust the staff in Iran. Some organizational level problems, for instance, lack of insurance coverage for all refugees, lack of a screening system when they arrive on the borders, inadequate organizational support, and low coordination among the different personnel, and social level issues as well. Unfortunately, the issue of discrimination sometimes exists in some provinces in Iran. There is a negative attitudes of some Iranians and healthcare providers, specifically among this kind of refugees. And unfortunately, the case of COVID-19 might have jeopardized the situation. And these are the challenges for providing the healthcare services, despite all those kind of benefits that they have been enjoying in Iran. I would like to finish by saying that Iran has been providing good healthcare services for refugees, specifically almost above 3 million Afghan refugees in the country in the course of last 4 decades. Unfortunately, the sustainability of finance, the lack of international support, and some kind of social issues has been somehow compromising the quality of and the quantity of the services. But we are keen to provide universal health coverage like Iranian citizens as a kind of humanity issues for this, because Iran has been very famous and world famous in terms of providing hospitality for people. And I want to finish by inviting you and offering you this a very interesting and humane poet by Sadi Shirazi, our very famous Iranian poet in the 13th century, says that human beings are members of a whole in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. Thank you very much for your attention, and I'm looking forward to our discussion at the end of the panel. Over to you, Özge.
Thank you for your presentation and the very meaningful quote, Professor Takyan. I'd like to continue with our third speaker, who is Professor Selma Karabey from Turkey. Dr. Karabey is a graduate of Istanbul University of Medicine and a public health specialist working in the Department of Public Health of Istanbul University of Medicine since 1986. In addition, she has been consulting in various boards of the Ministry of Health and the National Medical Education Accreditation Board in Turkey. Professor Karabey's current professional interests are public mental health, vulnerability, and advocacy in public health. She has been a board member of the Virus Association, which works in the field of community mental health, and she is a member of the Lancet COVID-19 Commission Humanitarian Aid, Social Protection, and Vulnerable Groups Task Force. Over to you, Professor Karabey.
Thank you, Özge. Good afternoon or good evening, all. And I'm very, very happy to be here, a part of this wonderful panel and colleagues. Thank you very much. I will try to talk about the situation of refugees in Turkey. As my colleagues said before me, Turkey has a huge number of population of refugee in the country, and so we have really gained big experience during this period. Turkey's own population is already more than 80 million, and plus we have approximately 5 million migrants, and most of them are Syrians under temporary protection, and there are about 400,000 under international protection, and also 1 million irregular migrants. And only 2 or 3% of the refugee population are living in refugee camps. The other ones are living in the community. I think Shadi has already shown the similar table, the immigration routes. Turkey usually is announced a transit country, not final destination, but already the actual conditions for most of the refugees now Turkey is seems at least a final destination. And I will try to talk about the conditions regarding with the COVID-19 pandemics. What are we doing in this period, and what are the problems still unsolved? I see that many of the problems are similar with other countries. There are some working conditions, also living in poverty and crowded houses is another problem regarding with COVID-19. And also there are many stress-provoking factors, of course. And I want to talk about some of the stress-provoking factors during the pandemics. And I am happy to say that we have great efforts by all institutions in Turkey during COVID-19 pandemics, including governmental institutions, non-governmental ones, and also UNHCR and the other UN agencies. For instance, Turkish Ministry of Health has been carrying out a project named Sıhhat Project, and approximately, as Shadi said, 200 migrant health and community mental health centers all around Turkey. And also, Turkey has provided universal health coverage to documented refugees, but primary healthcare are open to all refugees living in Turkey. And also, I'm happy to say that COVID-19 vaccination also has been applying to the refugee communities. Actually, Turkey has not enough amount of vaccination, but although this fact, with, for instance, Turkish healthcare professionals, Syrian healthcare professionals can have vaccination too, such like the other community groups, elderly, high-risk group, etc. Ministry of National Education also provides some quick solutions because of the pandemic. For instance, digital education opportunities has started, and a special TV channel has established, and also internet channels can be used for distance education. But of course, there are many problems regarding with the refugees to access the education opportunities. And we should mention about the important role of NGOs working in the refugee field. They are they have huge flexibility, and they're always working on solution-based. Also, they have close connections with the communities, and the people trust the NGOs. Those are, of course, big advantages to provide some services. As you see, there's a large network among the NGOs in Turkey, and Turkey really experienced in the NGO field regarding the refugees. One of the biggest NGOs in Turkey, of course, Red Crescent of Turkey. It is not a real NGO, actually. It is a para-governmental organization. Maybe it's better to name it. And Turkish Red Crescent in the COVID-19 pandemic period, they really make a good performance, and they established many multidisciplinary teams. They established some community centers, about 16 in Turkey, and they are providing some comprehensive health services, mental and health services to refugees. They, for instance, provide some treatment for people with psychiatric diagnosis, some health education, vocational course, etc., etc. And they are carrying out some activities with young people and children, even in the pandemic situation. And also, there are some activities regarding the women employment. They are sewing, and they are selling the products, and they earn some money through these activities. But of course, there are some groups that most affected by COVID-19, and women and children have more disadvantages among the all groups. For instance, during the pandemic, the risk of child labor has further increased, unfortunately. Of course, there are always some child labor, but during the pandemic, it increased. And because of the suffering financial difficulties, and because schools are closed, and seasonal agricultural work is common among the refugees, and also no television or internet access in the rural areas. And regarding the women, as you know, I think you know, UN Women name it a shadow pandemic, means violence against women during COVID-19. Unfortunately, gender inequalities deepened during the pandemic, and all types of violence against women and girls have increased. And on the other hand, during the pandemic, solidarity networks and services of support institutions limited, and security, legal aid and protection has become difficult. And I think this is my last slide. I want to emphasize that we must invest to women empowerment, because I know very well the situation of Syrian women living in Turkey. The education level is quite low. The employment opportunities is so limited. And also we have many reproductive health problems with those women: early marriage, early motherhood, and very high fertility rate seems the most important reproductive health problem. That's the all I said. And yeah, my last keyword, solidarity is everything. Thank you very much.
Thank you for presenting the current situation in Turkey, Professor Karabey. Now I'd like to introduce you our next speaker, Professor Mubarak Hosain Khan. Dr. Khan is the chairperson of the Department of Social Relations at East West University in Bangladesh. Before joining EWU, he had faculty and research positions at Bielefeld University School of Public Health in Germany, Sapporo Medical University in Japan, King Faisal University in Saudi Arabia, and Bangladesh Agricultural University and Jahangir University in Bangladesh. He completed his rehabilitation in urban health from Bielefeld University, PhD in public health from Sapporo Medical University, MSc in community health and health management from Heidelberg University, and MSc and BSc in statistics from Jahangir University in Bangladesh. His total number of publications is over 130, including an edited book on urban health in megacities. So please, Dr. Khan, the floor is yours.
Thank you. Can you hear me?
Yes, we can hear you, but we can't see you.
Okay.
And
it is stopped by the host, I think. And
okay, and would you like to share your screen?
Yes. You cannot start your video because the host has stopped it. So I don't know how to.
Yeah, maybe we will solve it soon from the office. Please give the right to Mubarak to share the screen. Just 1 second.
Okay, I think, yes, we can now see your screen.
Excuse me.
It's okay.
So I want to share my screen.
Yes, we do see your screen, and now we can see you as well.
Okay, but what about my presentation?
Yes.
We will see whatever, you know, so you have to make it a little bit larger. You know, if you can put it in full screen, your presentation will be easier for people to see it.
Okay, now you can see.
Okay, full screen, yes. And also you can put it in the presentation mode. It's easier for people to see it.
Okay, I think now it is okay.
Thank you.
Yes, yes, thank you so much.
So thank you, Dr. Kamen, for introducing me nicely. And also, I'd like to thank Luciano for inviting me to be a part of this scientific webinar, which is very, very timely. I also thank all the distinguished speaker and other participants for joining this webinar from different parts of the world. It is definitely a great pleasure for me to be a part of this event. Briefly, I want to introduce the outline of my presentation. First, I want to give you some information about the COVID-19 situation in Bangladesh. And then I want to show by one slide that COVID-19 is very, very dangerous, or it has a lot of impacts as compared to many other pandemic worldwide. And then maybe I can focus on Bangladesh, why Bangladesh is so important, and particularly why migrants' health are so important under this COVID situation. I'll also mention some impacts, key impacts, which was created due to COVID-19. And finally, I may highlight some of the possible strategies, what is already taken by the government of Bangladesh along with other international donors. So if you look at this slide, this is a summary of COVID-19 situation from the starting to until today. So the first case of COVID-19 was detected on March 8, 2020, and the first death was actually occurred after 10 days, that is March 18. And the total number of COVID cases until now is more than 540,000. And most of them recovered, over 90% already recovered. And the number of deaths, actually, it is over 8,000. And the case fatality rate is only 1.53%. And if you look at the last part of this slide, you can see the vaccination kicked off on January 28, 2021, very recently, but the worldwide, the countrywide vaccination started a few days later, I think 7th February, February 2021. So now we can see what is the trend of COVID-19 in Bangladesh from the beginning to the recent time. You see there is a report which is continuously published by WHO along with Bangladesh government. According to their records, the COVID-19 situation actually is improving, although it was very serious during the whole 2020, but after 2020, the number of cases and deaths actually are gradually declining. So it's a good sign for our country, but the problem is the impact. So to just give you some impression about the impacts of COVID-19, I give you some information highlighting information from different pandemics like Spanish flu, SARS, and then MERS, Ebola, and COVID-19. And a number of cases, for example, for Spanish flu was much more higher. I mean, about 1/3 of the total population were affected by the Spanish flu. COVID-19 like more over 2,200 over 2019,000. But the impact, if you look at the GDP, then COVID-19 impact, economical impact is so high. I mean, the GDP declined by 8.7%, which definitely indicates the devastating impact of COVID-19 as compared to other pandemics. By the way, this calculation is only done for the affected countries, not for the whole world. So actually, we know this is a very serious situation. Everyone is affected by this country. So everybody knows initially COVID-19 was considered as a public health crisis, but after this actually it is no more a public health crisis. Only it is now a crisis, and it can be seen in various dimensions. Already some of our previous speakers says it now creates problems, humanitarian problems. It is an also issue of development, and all the development activities are mostly stopped because of this COVID-19 situation. So it is definitely a very big problem what we are actually suffering. So I can also give you some other statistics. The global remittance, which declined actually by 20% already from 2019 to 2020. It's a big damage in our economy worldwide. So what are the overall impacts and how can we actually divide them? We can see the impacts of COVID-19, you can see at the local level, national level, and global level. Already it is highlighted. And these impacts you can at least make or divide it into three groups: economic or livelihood impacts. Other impact might be related to medical care, public health impacts, and also psychosocial impacts. Psychosocial impacts, and this diagram also indicates these impacts are interrelated, they are not separated. For example, if there is an economical impact, maybe it will create problems psychologically. If there is a psychological problem, maybe it can affect the public health system, and so on. So because of this, actually, I just want to highlight some statements given by WHO and some other organization. And WHO Director General recently said that COVID-19 is not just a public health crisis, but it is a crisis that will touch every sector. it is able to infect people easily and spread from person to person in an efficient and sustained way. So every sector and every individual must be involved in their fights. So it's a very strong statement, I think, which is 100% right for the whole world. Similarly, the ambassador of the delegation of the European Union to Bangladesh said the coronavirus pandemic is challenging economic and social systems globally. So both statements actually indicates the strong impact of COVID-19 on the global system. So now one question which may come to your mind: why Bangladesh in general and why migrants and informal workers in particular are the focus of my presentation? The answers are straightforward. First, Bangladesh is a labor surplus country, and because of its weak socioeconomic infrastructure and limited job opportunities in rural areas, many young people are jobless and they are trying to go abroad, mainly in the Middle Eastern regions and Asia-Pacific region. For example, each year around 600,000 workers migrate abroad. Currently, between 10 to 13 million overseas migrants are working across 170 countries in the world. This is the main reason why Bangladesh is considered as a massive source of overseas migrants. Most of these migrants and their families considered overseas migration as the risk minimization and capital accumulation strategy. The majority of the migrants' families heavily depends on foreign remittance sent by them. Foreign remittance is also considered as the economic lifeline to poor households in Bangladesh. Similarly, remittance is the lifeline of the economy of Bangladesh. So like overseas migrants, a huge number of domestic migrants and informal workers are engaged in low-paid jobs and informal activities in both cities and rural areas. Although total number of domestic migrants and informal workers are not exactly known, probably this number is 2.5 times more than the number of overseas migrants, according to World Bank information. And as I said before, they are mostly engaged in informal activities. According to recent study, it is over 90% of the labor force is employed in the informal sector in Bangladesh. So millions of these migrants, including their dependent family members, are facing serious difficulties in both host countries and within Bangladesh because of the COVID-19 and its containment measures such as loss of job, wage cut, lockdown, etc. These groups are definitely one of the most vulnerable groups in Bangladesh affected by COVID-19. Now I'll show you some statistics based on different surveys and reports included, which are conducted during the pandemic of COVID-19. One of the worrying statistics is here: the over 600,000 Bangladeshi overseas migrants already back home from overseas between January and March. This is a huge number, and 40% of the migrants who are still abroad are jobless, according to ILO. And estimated remittance is projected to decline from $18 million in 2019 to $14 million in 2020 in Bangladesh, which is a likely fall of about 22%, which is economically a big damage for Bangladesh. Over 55% of overseas migrants, returnees, and 71% of domestic migrants who returns to their origin, like village, were in debt. So this is some of the statistics which shows actually the economical impact of COVID-19 in Bangladesh. If you look at these statistics, then you can see it also affects the health determinant. I know health determinants means which affect our health, like nutrition, like economy, like food, like depression. All are determinants of health. And I want to just show some of the statistics. Livelihood, for example, was 94%, 1% said their livelihood were affected due to Corona. 42.5% of the vulnerable groups reported that they are facing economic hardship. 38.3% of the vulnerable groups reported they are facing from problems due to insufficient food supply. Also, a big number of them are psychologically affected. Some of them are in a severe depression, and because of their poverty condition in the households, many of them even went outside every day by ignoring the lockdown and other containment measures only for jobs. So these are the situation actually they are facing in Bangladesh due to COVID-19. Since I have very limited time, I just briefly mentioned some of the key impacts focusing on overseas migrants. You can see there are 5 key areas are identified by international level organization. One of the areas which is very important for migrants is overseas job decreases, especially in the Middle East, because these countries are well-based economy, and because of this problem, there is a lot of job cuts already done, and they normally target the foreign laborers. So there is a decrease in job. Also, those people who are still in foreign countries, they are also facing some kind of uncertainty whether they can continue their job or not. Also, those people who return to Bangladesh, they are now thinking whether they can go again to these countries because there is a lot of condition already imposed. So this is another problem for them. And new migrants who want to go to abroad, actually with a new visa, they are also thinking of their expiration of visa, because due to lockdown, travel bans and so on, these people cannot go. So this is another big problem. And the other main problem is economic uncertainty, because when the income is not regular, these people are suffering a lot due to limited income. Their livelihoods are already affected, already I mentioned, and also there are many other problems. There could be more problems, but because of short period of time, I just only highlighted some of the key impacts. Now, after impacts, now how can we deal this matter? What can we do? What risk reduction strategies can be applied? So again, I want to highlight some of the recommendations given by ILO, because these are the organization dealing labor issues. So I think they generate the most feasible and viable strategies, which is actually beneficial for the vulnerable groups like migrants. So they identified several areas. Like first they said one of the strategy could be to develop their skills, because as you know, in Bangladesh, the migrants are mostly unskilled and they are not very educated. So if they want to compete with other international laborers in the host countries like Middle East, they have to develop their skills. So they can get training on entrepreneurship, training on IT, information technology, or they can get digital training and so on. The other areas where the government can focus, like develop social safety net and social protection mechanism. This is purely a good approach in context of Bangladesh, but unfortunately, the social safety net and social protection measures actually are not up to the mark. So there is a lot of weaknesses still we can see. The third area where the Bangladesh government can work, they can make a database, because database for the returning migrants workers, because when somebody come back because of various measures like containment measure or other issues, if they are listed, if you have a database, then government can ask them what are the problems or why they come back to Bangladesh, or is there any problem from the host countries and so on. So if we have this kind of database, then the government can regularly follow up them and collect data and take feasible actions so that the rate of return migrants or their problems can be minimized. Since the remittance is the main source of development in Bangladesh, and most of the remittance actually are coming from abroad because of overseas migrants, or most of the remittance are coming due to garment sector, where mostly the informal workers are working, migrants, domestic migrants are working. So as you see, the first two leading sources of development actually are remittance, either by foreign overseas migrants or by the government sector. And these areas are mostly covered by informal migrants. So they should be treated with dignity and respect. They should not be ignored. They should not be discriminated, because the problem is nowadays, if somebody comes from abroad, they are immediately isolated in the society, because everybody is thinking, okay, he may have kind of coronavirus infection, he can spread this. So it is like a containment measure. So they feel some kind of discrimination. So this should be actually treated with honor and dignity. And yes, Bangladesh is already a very poor country, and the problem is huge. So in order to overcome the migrant issues, actually collective efforts, interministerial collaboration between government and other international stakeholders like ILO and other big World Bank and other organizations is definitely needed. And the last strategy could be like continuous need assessment is necessary, and also regarding financial assistance, what they want, like soft loans. I mean, with the minimum interest, the migrants can get this monetary assistance so that they can do something for them and also for their families. So these are some of the strategies actually which could be relevant for Bangladesh. And I think my time is already over. So I just want to conclude within one sentence. Actually, migrants are the most vulnerable groups who are affected by COVID-19. Here, migrants means actually not only overseas migrants, also domestic migrants and informal migrants, informal workers, low-wage people are included. So thank you very much for your patience hearing.
Thank you for your presentation, Professor Khan. Now I would like to continue with our fifth speaker, who is Dr. Pedro Gois. Dr. Gois is a professor in sociology and methodology at the Faculty of Economics, University of Coimbra, and a researcher at the Center for Social Studies. He's an expert in sociology of migration and quantitative methodologies. Recently, he was consultant for the International Organization for Migration, Caritas, ICMPD, European Commission, and European Migration Network. Over to you, Dr. Gois.
Thank you, Ozge. Thank you very much. I cannot share my screen until the previous speaker switch off. So
okay,
that's
so,
it.
Yes, I think now you can share.
Let's see. So can you see it? Yes, now.
Not yet, but yes, now we can see it.
Okay, so thank you very much for this.
Thank you.
So we will move from one continent to another, and we are moving now to Latin America and the Caribbean. And let me start. I will navigate in between only three concepts: the concept of collaboration, the protection, and coordination. COVID-19 pandemic is an unprecedented global health crisis that requires international transdisciplinary collaboration to address its broad-scale societal and public health impacts. In comparison to what was possible during previous pandemics, the information age and rapid advances in data-driven research can or could offer policymakers and scientists important tools to identify strategies and policy solutions. Strengthening the link between science and policy, if possible, if scientists, including social scientists, work together, leaving aside scientific nationalism. A new culture of sharing data is needed, and it's not present till the moment. And this is the momentum to do it. These expectations is that by working together, we will be able to offer reliable data to policymakers as part of our whole government approach. And those collaborative tools can effectively mitigate COVID-19 while minimizing the social, economic, and environmental impacts of the pandemic. The pledge to leave no one behind that was already presented in this seminar has been essential in making the plight of the need to include not only migrants, but let me complexify the concept to include people on the move, indigenous people, migrants, IDPs, and refugees in national healthcare systems worldwide. This was the case in Moria or in South Sudan, in Palestine, as in Australia, in the European Union, or in the United States. Within a global pandemic, there is no room for a chauvinistic vision of the pandemia. In Latin America, the current situation of indigenous people, migrants, forced migrants, IDPs, and refugees tends to be far more complex than elsewhere. Interregional and intercontinental migration have always been present in Latin America and the Caribbean, where most migratory movements remain interregional, informal, and non-registered. The main final the intercontinental destination of those migrants should be, it tends to be North America, but in the last few years is increasingly diverging towards Europe, particularly to Latin countries such as Portugal, Spain, and Italy. But the majority of cases remain in the intra-regional migration, was concentrated in states going through internal crisis situations related to political violence and human rights abuses, such as Venezuela and Nicaragua. The most developed countries in Latin America have usually shown signs of kindship towards the rest of the countries in the region, opening their borders to those who have decided or have been forced to migrate. This is the base of the Cartagena Convention and regional and more advanced Refugees Convention added to the 1957 UN Convention. The recent years are very representative of this ideal, with the migration of millions of Venezuelans to neighborhood countries. Within the migratory process that began in Venezuela in the second decade of the 21st century, an estimated 5+ migrants have settled in different parts of the world, accounting for the largest migration flow in such a short time in the history of Latin America. The greatest number of migrants added for Colombia, where the last official register of migrants included more than 2 million people coming from Venezuela, making Colombia the second biggest host of refugees in the world. The composition of migrants in the region by country varies, and so does the social and political acceptance of those groups. For instance, Chile has a high number of Haitian, Peruvian, and Colombian migrants, whilst Costa Rica hosts mostly migrants from Nicaragua. In Brazil, the most common groups are currently Venezuelan and Haitian migrants. However, global migratory trends were, here like elsewhere, changing rapidly before the pandemic, with a significant increase in immigrants from Africa and Asia arriving to Latin America countries or using those countries as transit countries for traditional destination. There was an halt on these migrations, but they will recover very soon as they can. Leaving no one behind in Latin America during the COVID-19 pandemic means that governments, international organizations, NGOs, and other stakeholders alike should take a convergent social responsibility for immigrants' welfare through immediate actions such as access to healthcare and the inclusion of those individuals in vaccination plans, but also in education, social, public health, and immigration policies in the long term. Much of what happens in relation to these various group of migrants will depend on the response not only from local communities, but from local governments, and in our view, it's a call for a direct action on the international multilateral organizations that are already in the region working with migrants. Just to name a few, OIM, UNHCR, WHO, UNICEF, etc. They all need to work together to create a task force to attack the virus and the virus health and social consequences directly connected to those millions of persons in the move. This is not a work for the local governments only. This is a work for global community. The current COVID-19 pandemic outbreak is affecting all countries and societies in the region. While travel and mobility restrictions have limited the spreading of COVID-19 and mitigate the health risks for the entire populations, other risk factors for community transmission related to living and working conditions for all migrants have continued as a result of discrimination and protection gaps. Vulnerability in the context of human mobility is socially invisible because migrants are still on the move, in caravans or isolated, because they just arrived to the countries of destination, because indigenous, migrants, forced migrants, IDPs, and refugees are physically present in communities, yet socially excluded in every other way. In Latin America, vulnerability in context of human mobility does not normally reside in refugee camps. Those indigenous, migrants, forced migrants, IDPs, refugees, or people on the move tend to have little access to social protection and healthcare, and in most countries are still excluded from the national healthcare systems. Furthermore, within the region, there are reported situations of human trafficking for sexual exploitation and to be used as low-priced or slave work in the sweatshops or extracting industry, agribusiness, deforestation industry, and are creating shocking cases of abuse, especially of children and women. The pandemic has also increased inequality between migrants. Even those migrants that are already inserted in the labor market are more than ever socially vulnerable. Work in Latin America and the Caribbean is highly segmented between formal and informal employment. The vast majorities of workers in Latin America and the Caribbean countries are in informal jobs without access to the types of support that workers in rich countries get from their governments, such as furloughing schemes. They are marginalized and overcrowded in overpopulation urban settings, and they are experienced as never the many aspects of deep poverty and radical social exclusion. Additionally, in the past year, the economic activity halt has increased the vulnerability of migrants in the different countries of the region and has indirect consequences in the countries of origin, as we have just heard for Bangladesh. Not only was informal work more vulnerable during the shutdown, but migrants appear to be disproportionately working in the informal sectors most heavily impacted by COVID-19 shutdowns. The quarantines, it particularly hard those migrants and the poor who depended on daily informal work on the streets and in fields to feed their families and pay rent. Without income, the poorest migrants throughout the region can't send remittances to their families or pay pay rent. Remittance for migrants represent a way to pay for basic social needs back home. Sometimes they work as primary income source for the family. The economic crisis already in place is the sign for a deeper social crisis forthcoming. Without income and remittances, it's not only the migrants that are struggling, but their communities back home. We all know the impact of social determinants on health. We all are aware of the future impact of the pandemic consequences. There are also good examples in the region. All South American countries provided the emergency medical care during COVID-19, regardless of immigration status. What was rarer for poor and uninsured migrants was access to non-emergency care and testing, so critical to catching the virus early and staving its worst effects. No country in the world was prepared with a sufficient emergency health, social, or economic policy framework adequate to combat the coronavirus outbreak. In Latin America, with 18% of the cases of the COVID-19 cases in the world, it has 27% of COVID-19 deaths. Latin America and the Caribbean faced enormous additional challenge from its own structural inequalities, record number of migrants, and already inadequate funding for migrant host countries even before the pandemic hit. Access to the COVID-19 vaccines will determine the scale and speed of recovery from the pandemic. This is likely to differ from across region per countries and across different social groups within countries, further accentuating inequality. Many nations in the region are not expected to vaccinate substantial parts of their population until 2022, and some, such as Nicaragua, will still be struggling with vaccination well into 2023. Migrants will be in the end of the line in all these countries. After every single major outbreak, and you can go back to SARS, to Ebola, you see the same pattern as in many of the humanitarian disasters. A lot of money goes into response, and then it simply disappears right afterwards. This time, it's not possible to do the same as we did in the past. Ongoing COVID-19 pandemic endangers everyone everywhere. But the pandemic also reveals the great inequalities and fragilities that exist in our societies. In Latin America and Caribbean countries, social and economic differences that have long existed are now starker than ever and will be even severer in the years to come. This highlights the need for rethinking both the scale of international support needed and the institutional delivery mechanisms to provide it to such a large population in the long run, in Latin America, but also globally. Collaborate, it's the key for our success in the future. Thank you very much.
Thank you for your presentation, Dr. Goiz. Today, our last speaker is Dr. Claudio Brando. I'm sorry, it's always the most difficult to be the last speaker. But Dr. Brando is a medical doctor and a gastrointestinal surgeon. He is the Chief Academic Officer at the Javeriana University Hospital in Bogota, Colombia. Dr. Brando is an advisor for Latin America of the Association of Academic Medical Centers and member of the Commission for Human Talent in Health of the Ministry of Health in Colombia. So the floor is yours, Dr. Brando. We can't hear you right now. Dr. Brando, are you on mute?
Yes.
Okay, great. Now we can hear you. Thank you.
Hello. Good morning, good afternoon for everyone. It's a pleasure to be able to meet again as we did it 2019 in Washington and Rome under the leadership of Luciano. Quickly, I want to update the Venezuelan migration situation that was the object of our presentation, and today referring to the impact of COVID and the economical consequence that are finally one of the main drivers in the situation of migrants and refugees. Mr. Maduro continues as president of Venezuela. Elections were held where the opposition not present to these elections, and Mr. Guaido, previously recognized for more than 50 countries as interim president, lost momentum and his position is vacant right now. The economical situation reaches the lowest point in Venezuela with inflation over 1 million, and the situation get the bottom and start improving when the dollarization of the economy started. But the blockage of the United States to the Venezuela makes a very difficult transit to the unofficial currency in Venezuela right now is the US dollars. In Colombia, the pandemic hit very hard the country. By 2019, the GDP in Colombia was 3.3% increase. It's better than the average for Latin America. And the forecast for 2020 was very, very good, plus 3.5%. But COVID, with the absolute quarantines, the fail in the oil prices, put us in a very difficult situation, losing from +3 to -6. And the impact was not only in the GDP, also on employment that arrives to 21%. And this situation was not only for Colombia, was all countries receiving Venezuelan migrants in Latin America. And this situation hits very hard all the migrants receiving countries. The first cases in Colombia start in February 2020, and the mandatory quarantines by March 2020. In April, started phase 2, return to Venezuela. The governments of both countries start 3 points to pass the migrants, but the position of Mr. Maduro, the previous policy of open arms, receiving the return of the nationals in these minimal quotas of 100, 200, 100 people, finally closed the borders, left thousands of Venezuelans in a catastrophic sanitary condition stuck at the border post. And this not only happened in Colombia, also happens in the Caribbean, and all the countries in Latin America closed borders during the COVID. And just from the 4 million to 5 million migrants, just 1,000, 5,000 come back to Venezuela through Colombia. This forces the migrants not only to stay in the border, also to get stuck between Peru and Ecuador and Chile and Peru, stuck on the borders. All the borders were closed. They choose to travel to not legal borders, and these not legal borders were very dangerous because are used by the drug dealers and illegal forces. So Colombia decided 2 weeks ago to start a temporary institute for protection of the Venezuelan migrants. And this allows 56% of the Venezuelans in a regular condition guarantee the integration and care of the irregulars inside the national. They already have healthcare and education for their children, but now they can stay under a special condition. And they're able to carry any legal activity inside the country and also apply for visa residence if they decide to stay in Colombia. But the COVID make another different situation, like Pedro told. Colombia is the second country in Latin America with more cases of COVID and the third with more deaths related to COVID. Colombia decided just to put all the beds inside the Pfizer vaccine and other vaccines. That situation put us, Colombia and Venezuela, together in the last start of the vaccination, with just similar to the sub-Saharan countries. And Venezuela already received something like 100,000 doses for the healthcare and the officials of the government, but Colombia just received 40,000 vaccines. And the situation maybe then Colombia and Venezuela may be late 2022 or early 23 to get vaccinated in this situation. Thank you so much.
Thank you, Dr. Brando. And over to you, Luciano.
Yes. Okay, so I would like to thank all the speakers for the excellent presentations, very interesting. And before starting the discussion, I would like to ask Dr. Mohamed Sayag, the chair of the steering committee of AAHCI, to say a few words. Dr. Sayag is an eminent leader who served for many years as Dean of the Faculty of Medicine and Executive Vice President of Medicine and Global Strategy at the American University of Beirut, and is currently the chair of the AAHCI steering committee. Please, Mohamed.
Thank you very much. Sorry, I have had initial problems with login, and for some reason the camera is not working, but I think you can hear me.
Yes.
And I really enjoyed the presentations. They're very interesting. Obviously, this is an extremely important topic. I want to thank Luciano for really taking the effort and putting this together. As you know, Luciano, we have been working since I became chair of the AHCI steering committee on fostering more and more inter-regional collaborations, not to stick with one region. And obviously you have started this before us with the M8 Alliance. But I think this collaboration between AHCI from different regions and the M8 Alliance really gives a very important message from this conference, and for such an important topic that actually crosses also regions and crosses countries and crosses continents. So I want to thank everybody for organizing this and for the speakers. We are hoping that we will do more of these on other and different topics. And please, for the participants and for the speakers, if you have other ideas, other topics, please let us know. Luciano, myself, and the group, we would be very happy to follow up on them. Thank you very much. And sorry for the technical problems.
Thank you very much. That happens. And I give again the floor to Oscar to chair the discussion.
Thank you.
Thank you. Thank you, Luciano. So in the last 10 to 15 minutes, we would like to continue with the Q&A part. Our first question is from Alexander Kramer from Bielefeld University. And the question is to Dr. Takian and to Dr. Karabey. There seems to be a big difference of the relation of illegal versus registered migrants in Turkey and Iran. Why is that the case? What are the procedures for registering refugees in the two countries? Does this affect the health situation of refugees? And if so, how? So, Dr. Takian, would you like to start?
I always believe that ladies first, so I would like to start with Selma and then I will start.
Okay.
Okay.
Thank
you, Amir. Very kind of you. Yes. Actually, before the 2015 in Turkey, the situation of the refugees was not clear. There are millions of Syrian refugees and the other ones, but unofficially, Turkey doesn't accept the people from the eastern countries as refugees. But there are millions of people in the country, and so what will be the situation? And luckily, in 2015, a new legislation was made, named a temporary protection law. And according to this law, the people forced displacement and came to Turkey legally or illegally, actually. They can apply for the registration, and the government will examine the documents and then give the registration right. Because of the law, this new law, many people can reach the documented refugee status, and all health services, all, of course, national state health services, public health services are open to those people, and all educational opportunities are open. And so this is very, very good, of course, for the refugees. But there are a considerable amount of undocumented refugees, unfortunately. And again, educational opportunities, schools are open and basic health services are open, but other services are restricted. But during the pandemic period, regarding the health issues with COVID-19, all of healthcare services are open to all people in Turkey. I think for now that's enough. Thank you.
Thank you, Dr. Karabey. So yes, over to you, Dr. Takyan.
Thank you very much, Ozge. And I'm seeing lots of Turkish delights behind Professor Karabey. So I wish we could have a share of those Turkish delights as well. Thank you very much, Professor Kramer. These are very important questions. In terms of the differences between the two concepts of illegal and undocumented, unfortunately, the situation is Iran has been hosting in the last 4 decades after the war in Afghanistan, this 3.5 million refugees from Afghanistan. The ones who look after the legal situation and legal status, they have something which we call Kart-e Amayesh, or it is a kind of residence card for them. When they have this, they can apply for jobs, they can go to the university, to the school, they can enjoy the free healthcare services like Iranian citizens and everything. The problem is, so many of these refugees have passed the borders, and unfortunately, they haven't applied for the legal status. This has taken decades, but unfortunately, that's the case. We know they exist. We have been trying to somehow not encouraging them to stay at the illegal situation, but at the meantime, for humanity and human reasons, we have providing things. Up to 2014, if they were illegal and undocumented, and both are the same, they could not have enjoyed access to education and free healthcare services. But since 2014, our eminent supreme leader, they have a decree, and now we provide them everything like the legal ones for on the illegal ones as well, based on human right and humanity. As I said, since 2014, we have been encouraging them to register for universal health coverage with a very little nominal fee. And unfortunately, the majority of them have not applied because they are not very old, they are young professionals. And if they go from my country, most of the construction and the labor comes down because they provide a big market, but not in the formal sector, in the informal sector. So this dilemma still exists. So in the case of Iran, they are illegal as long as they are undocumented. They can be persecuted and they can be deported, but we have been providing this hospitality to them. And in terms of healthcare, they are pretty much the same between the legal and illegal ones because of the human reasons. I hope this has satisfied you, the answer to your question, Professor Kramer. And I would like to say that we are very grateful to Professor Alexander Kramer because we are working in the international comparison between these Afghan refugees in Iran and Germany. And he's leading, we are both PIs in the project that we are working to compare the situation of Afghan refugees in Germany and Iran. And hopefully in the next webinars and so we will have some data to compare. Over to you, Ozge. Thanks.
Thank you, Dr. Takyan. So in our last 10 minutes, I would like to ask 2 quick questions to all of our speakers. One question is from Dr. Redondo from Portugal, who is a psychiatrist. He asks what strategies are being implemented to reinforce mental health for vulnerable groups, including refugees and migrants. So maybe you can just mention one strategy to promote mental health for refugees and migrants in your own contexts. Maybe we can start with Dr. Saleh. Dr. Saleh, do you have any example
to
promote.
Repeat what you said, because I had cut off in the voice.
Yes, I'm sorry. So the question was, what strategies are being implemented to reinforce mental health for vulnerable groups, including refugees and migrants, in your own context? So can you just give one example from Lebanon?
Sure. I think one of the good I don't want to say byproducts, but the advantages of the increase in the number of refugees in Lebanon was real activation and investment, both by the Ministry of Public Health and by international donor in mental health. And a decision was made to integrate mental health services within primary health care, simply because of the burden that refugees had because of all of the displacement and so on and so forth, but also because Lebanon had relatively a good primary healthcare infrastructure that was able to absorb that. Now, in the first few years, that has evolved institutionally into having a division of mental health within the Ministry of Public Health that wasn't there before. It was activated. However, something happened which I'm interested in also hearing from other panelists whether that was the case as well. As we pile more and more services on primary healthcare, including non-communicable diseases, including women's health, including child health, and mental health, the capacity of healthcare providers, whether physicians or nurses, in primary healthcare becomes a little bit stretched, especially with the huge influx of refugees. And I think in the last 2 to 3 years, we're seeing that between all of the services that primary healthcare had to sort of decrease a little bit or focus less on, unfortunately, mental health was one of those. So I'm also interested to know whether that is the case in other countries as well.
Okay.
Thank you, Oscar.
Thank you so much, Dr. Saleh. So, Dr. Gois, would you like to say a few words? Just mention maybe one strategy.
Well, to be honest, we don't know a lot on this issue regarding to Latin America. It's very invisible for the moment. We are still living the pandemic, so there is this emergency run to save people in the emergency services, and so mental health issues or disease, they will they are coming to the front line in the emergency services, but regarding prevention, there's not much to talk about it for the moment. Even in the border areas where migrants were stopped, most of the international organizations, they stopped giving care to migrants for a few months. They were just returning after the first wave, but then there was a second wave of the pandemic, and they stopped providing care again. So it's an in-between moment. Let's hope we will return to action very soon.
Thank you, Dr. Gois. I mean, you are right that even in normal times, mental health is not a priority in many places. So during the pandemic, probably it's the same situation in many places around the world. Thank you. So Dr. Brando, would you like to say something about mental health or any kind of intervention?
Yes. No, we are very interested in our dean is psychiatrics. So we are very concerned about mental health. Let me tell you, we include the Venezuelans inside our community. They are not refugee camps. They are living with us, and the mental health care is given by the community health, and the community health service inside every social hospital or any medical hospital not specific in camps because we don't have camps of refugees. It's inside the health camp.
Thank you. Thank you so much. And Dr. Khan, you are on mute, I think. We
Yes.
cannot. Yes, now
Actually,
we can. Thank you.
I'm frequently disconnected during this session. I don't know why. Anyway, so the question is very important and relevant for COVID-19 mental health. In general, the mental health issues in Bangladesh is neglected until now because we have many other problems. But during this COVID situation, realizing this matter, the Bangladesh government and other development partners, they're trying to help the poor peoples, migrant workers and informal workers, so that they can be better in terms of mental health. So government is giving some money for cash money, for example, to the migrants. Immediately when they reach airport, for example, from foreign countries, they're getting some money. Also, informal workers, they're also getting some money through government systems, welfare systems. Also, the garments factories, which is the main income source in Bangladesh. The government gives a lot of money to this owner of the garments so that they can pay regularly to the garments worker because their jobs actually were terminated because of this problem. So in multiple ways, actually, government is trying to improve the mental health conditions of the poor families. So Bangladesh is trying, but again, it is not adequate. It's very minimum level. We need more and more support to maintain good mental health. So thank you.
Thank you, Dr. Khan. And Dr. Takia, would you, Dr. Takian, would you also like to add something about mental health? Yes.
Yes, as I mentioned, in terms of mental health, unfortunately, because of the stigma which we have in our culture, and specifically because the majority of our refugees are among the undocumented ones who are afraid of being deported, we have been facing a huge problem. And added to that is the majority of these refugees have left their families in Afghanistan, and they live on their own as the labor workers. They work very hard. Sometimes they go back to their home country every 6 months. So I should confess that we haven't provided kind of enough services for mental health, but we have two things. One of them is more advanced. Another one is in the pilot. One which is more advanced is community-based rehabilitation facilities that we have across our primary healthcare network for people with disability, including the ones with mental health, with the help of the government and totally funded by the Ministry of Health and Medical Education. That's on the kind of larger scale and expanded. In terms of mental health consultation, in 5 cities out of 440 cities in the country, in 5 cities, including the capital city of Tehran, recently, with the help of municipality and the charities, we have established mental health and consultation service facilities specifically for Afghan refugees, which is not too many of them, but still it is the good initiative to move forward. But unfortunately, I have to say that the COVID-19 situation has jeopardized the status of this and somehow has affected in somehow adverse ways the funding and the facilities available for that. This remains a big challenge we have to tackle. Thank you.
Thank you so much. So actually, I was going to ask one more question, but we don't have time. So I'll just mention the question and the recommendation from Professor Dr. Taceddin İnandı from Turkey. He says that building peace is a key solution for migration-related problems and also for the whole population. So he was actually asking, is there any strategy or an effort in building peace in your own country? Is there any educational target or aim in terms of building peace? And he believes that we need lectures related to building peace in medical schools and public health schools. And I believe that's a very important thing to consider for future. So I would like to thank all of our distinguished speakers and to Professor Luciano Sasso for organizing and contributing to this event. I also would like to thank our audience for their active participation and valuable contribution. I hope to meet in another event of the M8 Alliance, and hopefully this time we can meet face to face. Thank you, and over to you, Luciano.
Thank you very much, Özge, for chairing so well this session. Also from me, many thanks to all the excellent presentation, to the speakers for the excellent presentations. I would like to thank also the participants for having been with us for more than 2 hours. And also again to the M8 Alliance, to Nora Anton, to AAHCI, to Dr. Sayag, to Chris Smith, to Biba Osmani. And we're looking forward to seeing you again at one of the next webinars. I sent in the chat the next dates, and also the link to the M8 Alliance webpage dedicated to migrant or refugee health. We hope that you will follow this series. We are having really excellent speakers and excellent discussions. And we have to say that we are sorry that we cannot meet in person, but also that these are also good opportunities to meet online and to have speakers from all over the world gathering on this event. So thank you again to all, and see you soon.
Thank you.
Thank you very much. Take care.
Bye-bye.
Bye.
Thank you.
Bye.
Take care.